Hi everyone, I'm Dr. Michael Richmond, a double board certified cardiothoracic surgeon. So in a previous video, I talked about papillary thyroid cancer. And as you remember, I said that's the most common cancer of the thyroid gland. So today we're going to talk about the second most common type of thyroid cancer, and that's called follicular thyroid cancer. So what is it? Well, it's a well-differentiated tumor of the thyroid tissue, and as I said, it is the second most common after papillary thyroid cancer. And it's more common in iodine-deficient areas and tends to occur in an older population when compared with papillary thyroid cancer, and it represents roughly 4 to 11% of all thyroid cancers diagnosed in the United States. Okay, so as I discussed in the prior videos about thyroid nodules, most patients with follicular thyroid cancer present with a solitary thyroid nodule. Not all, but most. So fine needle aspiration biopsies are then done, again, as we discussed, but they cannot distinguish often between follicular adenomas, which are benign, and cancers. So these FNA specimens are also called indeterminate lesion, which are usually called, depending on where you are, follicular neoplasm of unknown significance or atypia of undetermined significance. But the actual diagnosis of follicular thyroid cancer requires histologic evaluation of the thyroid after surgery with the identification of tumor capsule and or vascular invasion. And that's what distinguishes a benign from a malignant lesion, is they don't have invasion in benign. Papillary and follicular cancers are treated similarly despite numerous biological differences. The optimum treatment, however, remains controversial as there is a lack of randomized controlled trials comparing various modalities in follicular thyroid cancer. So, therefore, treatment strategies for follicular cancer are based primarily upon indirect evidence from papillary thyroid cancer data. But at the end of the day, treatment should be based upon risk assessment of each individual patient, not generalized. An important part of treatment is continued reassessment of the risks of recurrence and mortality as new information is gathered during follow-up evaluations. But what is the primary modality? Well, it's surgery for all patients with differentiated thyroid cancers. A preoperative ultrasound is important for the planning of the surgical procedure. Okay. So what are the procedures? Well, they include a partial thyroidectomy, which is called the lobectomy, or a total or complete thyroidectomy. Sometimes on final pathology, however, there are high-risk features identified which necessitate another operation for the completion thyroidectomy. Lymph node management is selective. Unlike papillary thyroid cancers, where we do what's called the central lymph node dissection, a prophylactic lymph node dissection is not routinely recommended, as follicular thyroid cancer rarely metastasizes to lymph nodes. A therapeutic neck dissection, which in other words, it helps people, is reserved for patients with clinically involved lymph nodes. The postoperative management includes treatment with thyroid-stimulating hormone levothyroxine in most patients and radioiodine in high-risk and selected intermediate-risk patients. Patients who have advanced or metastatic disease, the management includes radioactive iodine for iodine-avid metastasis, surgical resection of isolated lesions when feasible, and consideration of systemic therapies, which is multi-kinase inhibitors for radioactive iodine refractory disease. Okay, so not chemotherapy, it's multi-kinase for refractory disease. Now, who should have next generation sequencing, as I talked about? Well, that should be considered for patients with follicular thyroid cancer who have cytologically indeterminate nodules, which are known as Bethesda 3 or Bethesda 4, to improve diagnostic accuracy and guide management, as well as those for advanced, progressive, or radioiodine refractory disease, to identify actionable mutations for what I said, targeted therapy, which are multi-kinase inhibitors, and there's multiple ones depending on the targetable mutation. Okay, so with that, I hope you learned something today. Thank you so much for listening. For more information or medical guidance, you can go to my website at www.paladinmds.com. And we're going to cover in the next video the final two types, which are medullary thyroid cancer and anaplastic thyroid cancer. Okay, have a good day.